Graves ophthalmopathy having bilateral exophthalmos and lid retraction. The condition can be unilateral, could be bilateral. It's a most common condition in adults presenting with proptosis. The risk factors could be either hypo or hyperthyroidism or even a euthyroid state. The risk factors are female sex with smoking history, a middle-aged one with autoimmune thyroid disease. Pathogenesis is it's an autoimmune disease where fibroblasts and extraocular cells are involved. There will be excessive fibroblast proliferation and extraocular cells will be getting enlarged. The reason why the orbital fibroblasts are involved is because the target antigen is shared between the thyroid follicular cells as well as the fibroblasts. So extraocular cells are enlarged and orbital soft tissue also will show increased amount of mucopolysaccharides and infiltration with all the lymphocytes and plasma cells. A clinical profile: retraction of the upper lids, that is the dull dimple sign, and lid lag, von Graffi sign. Puffy edematous swelling and fullness of the eyelids is Enroth sign. Difficulty in eversion of the upper lid is Gifford sign. Infrequent or decreased blinking is the Stellwag sign. Increased pigmentation of the lid is a Jelinek sign. Poor forehead wrinkling on looking up is Geoffroy sign. Conjunctival sign include chemosis, and other ocular mobility defects is the Mobius sign, that is convergence weakness, or it could be even complete immobility of one or all the extraocular muscles. Inferior rectus is most commonly involved. There will be the elevator palsy, and then next to inferior rectus is the medial rectus muscle and thereby the failure of abduction. It's a restrictive ocular myopathy. Exophthalmos is the second most common and classical sign. As a rule, both eyes are symmetrically affected, but even we can see unilateral proptosis. So, the Graves ophthalmopathy is a commonest cause of both unilateral as well as bilateral proptosis in adults. And we have exposure keratitis and symptoms of ocular surface discomfort, thereby sandy, gritty sensation, lacrimation, photophobia. That's all because of upper eyelid retraction, exophthalmos, lagophthalmos, inability to elevate the eyes, and decreased blinking rate. And next, because of compression, there could be optic neuropathy, and that may manifest as papilledema and optic atrophy. According to the American Thyroid Association, the classes are categorized and there is an acronym: no specs. N is no signs and symptoms. Class 1, only signs and symptoms, only signs and no symptoms. Next is S, soft tissue involvement. P, proptosis. E, extraocular muscle involvement. C, corneal involvement, exposure keratitis, and S, sight loss. The investigations could be the thyroid function test and thyroid autoantibody assay. On ultrasonography, we can detect the changes in the extraocular muscles. Enlargement of the extraocular muscles without the enlargement of the tendon is a hallmark of thyroid ophthalmopathy. So first, there must be an order of involvement of extraocular muscles: I, M, S, L, O. Inferior rectus, medial rectus, superior rectus, lateral rectus, and obliques. CT scan will show the proptosis, muscle thickness, and any optic nerve involvement. MRI is also better if any soft tissue involvement must be noticed. Management would be periodic clinical workup, and thereby there is a clinical activity score based on pain: retroorbital pain, pain on movement, redness, redness of the lid, redness of the conjunctiva, swelling, swelling of the lid, swelling of the conjunctiva, swelling of the caruncle, and proptosis greater than 2 mm over the 1 to 3 months. Loss of function, decrease in eye movements, or decreased vision by greater than 1 Snellen line over 1 to 3 months. So clinical activity score is given, and non-surgical management is basically smoking cessation is advised. Head elevation and cold compression in the morning help in reducing the periorbital edema. Lubricating artificial tear drops and guanethidine 5% eye drops to reduce the lid retraction caused by overaction of the Muller muscle, systemic steroids, radiotherapy, chemotherapy, combined therapy of steroids, azathioprine, as well as radiotherapy is more recommended. Surgical therapy, where acutely progressive optic neuropathy has occurred, or exposure keratitis, or patients not responding to steroid therapy, there is a stepwise surgical approach. Orbital decompression is done, first medial wall, then inferior wall, then lateral wall, and then superior wall. And extraocular muscle surgery, inferior rectus recession is the most commonly performed surgery. And eyelid surgery, where Muller muscle and levator palpebrae superioris disc insertion is done. Blepharoplasty can be done, where removal of excess fatty tissue around the eyelids